All right, hi everyone. This is Lola Nudich. I'm the coordinator of the Harvard and Beth Israel Deaconess Medical Center site for the New England MHTTC. Please feel free to introduce yourself in the chat box if you would like. And now I just want to review a few housekeeping items before we begin. Participant microphones have been muted at entry. You will be able to unmute them during the discussion portion. This presentation is being recorded and it will be available on the MHTTC website. Once it is available, I will send it out to all participants. If you have any questions about applying for CEs for this webinar, I'll send an email about how to do that in the event follow-up. And if you have any technical questions about Zoom or anything, you can just message me privately using the chat. And with that, it is my pleasure to hand it over to Kelsey for introductions.
Sure, and I'll just pull up the screen here so you can see the lovely beginning of the slides that we have. Sorry about that. So I'm here to introduce three people who we've worked very closely with. Michael Stepansky, Margaret Geyer, and Emily Gagan. Really today's talk is about the great work that they've been doing over the last couple of years to really expand the mental health system that we have here in Massachusetts. First of all, here we go. First of all, Michael Stepansky is the Massachusetts Department of Mental Health's Senior Manager for Policy and Program Implementation. So Michael has a background in housing and supported employment and has provided a lot of training and technical assistance to our psychosis treatment teams across the state of Massachusetts. So over the past year, Michael has been particularly involved in implementing parts of the DMH's roadmap for behavioral health, which he'll talk more about today. And then Dr. Margaret Geyer is the director of the Massachusetts Department of Mental Health's Early Psychosis Initiative. So she is responsible for identifying, evaluating, and disseminating different evidence-based practices within the Department of Mental Health and among the different community providers in Massachusetts. So Dr. Geyer is a clinician and a researcher and has worked with people with severe mental illness for over 20 years at this point. And then lastly, Dr. Emily Gagan is a licensed clinical psychologist at the Brookline Community Mental Health Center. So Emily is the director of the Massachusetts Psychosis Access and Triage Hub, and also a member of the team at the Center for Early Detection, Assessment, and Response to Risk, also known as the Cedar Clinic. Dr. Gagan has worked with individuals with psychosis and schizophrenia spectrum disorders for 15 years and also specializes in the treatment of young adults with early psychosis. So great team that we have today, and also I think particularly close to our MapNet group. With that, I'll stop my share and Margaret, hand it over to you to pull it up.
Okay. Okay. Can everyone see the slides? Assuming the answer is yes. I'm going to turn the podium over to Michael in a moment. But first of all, I just wanted to thank everyone for being here today. And what we're going to be doing is presenting on the behavioral health roadmap and some of the new developments in the past 6 months or so here in Massachusetts. And then we'll be speaking to how early psychosis is woven into that. I think that we will very much appreciate questions. While we're talking, if you could put questions into the chat, then we will catch them after, unless there's something like urgently that needs to be asked while we're speaking. But we're going to leave lots of time for chat. So let me turn it over to Michael now.
All right. Thank you, Margaret. All right. So actually, if you can head over to the next slide. We really wanted to cover today, sort of as Margaret was saying, sort of changes in how Massachusetts is delivering mental health and behavioral health services, and particularly kind of the implications of that for first episode and sort of early onset psychosis. And so I think to start off, I want to just speak sort of very briefly about the behavioral health roadmap in Massachusetts, which is really the sort of framework for everything else that we're going to be talking about. I think after that, I'm going to speak a little bit about the CBHCs, which hopefully everybody has sort of heard about by now. Margaret will speak to the behavioral health helpline kind of here at DMH. And then Dr. Gingen will speak about empath. And then sort of as Margaret was saying, we should have plenty of time for questions afterwards. Okay. So next slide. Okay. So possibly, hopefully, people have heard about the behavioral health roadmap. And it really is the kind of guiding framework for the CBHCs and the helpline and a whole bunch of other things, which we'll maybe touch on in a little bit. And the roadmap sort of really was developed a couple of years ago, sort of just prior to COVID, and it involved really a sort of massive and comprehensive sort of outreach effort within Massachusetts to speak to all manner of stakeholders in the behavioral health system to sort of uncover and probe, where are the gaps and the cracks. And I think a lot of those gaps and cracks were sort of identified around how people access services, the sort of fractured nature of our services, having to go to different places for sort of different different issues, albeit interrelated. For instance, having to go to one place for mental health treatment, one place for substance use treatment. And then, sort of also primarily sort of the kind of over-reliance or sort of reliance on EDs or emergency departments for sort of as a sort of stopgap kind of intervention for mental health sort of in a way that they were never really intended to be. So the kind of focus of the roadmap really was driven sort of from these findings about kind of our sort of fractured system, and by default, people going to emergency rooms. So, I think we know that when things are confusing or complex, people tend to go to what they know and what is most easily accessible, and generally that is going to an emergency department. And so the roadmap really wanted to sort of get at that sort of specific issue to take pressure off of the EDs, and kind of by that get people sort of better, faster, sort of more comprehensive service in their communities. So next slide, please. Okay. So I will not read this entire slide, but this is really just to show how the helpline and the CBHCs are part of a bigger sort of network and web of interventions which make up the roadmap. So we're going to spend sort of most of our time talking about the CBHCs and the helpline, but there are also behavioral health urgent care centers. There are different initiatives happening around sort of integration of behavioral health into primary care, insurance, sort of other initiatives related to sort of discharge planning from EDs, sort of expanded crisis stabilization services, sort of et cetera. So, so the helpline and the CBHCs are sort of two foundational parts of the roadmap, but they are definitely not the whole roadmap. And there is more sort of coming online now and into the future. So that's that. Okay. So CBHCs. So the CBHCs, the Community Behavioral Health Centers, are primarily an enhancement to our existing system, not a replacement. That there was a lot of, I think, concern about this when the CBHCs came out, if they were sort of being substituted for other services that we have in the community. That was not the case. They are kind of adding to, enhancing sort of our existing system, and they're really predicated on a model of getting the right care to people in the moment, where they need it, when they need it. So there are 26 CBHCs in Massachusetts right now. Every community in the Commonwealth is covered by a CBHC. And those 26 CBHCs, I think, operate on 29 sites. So the vision and the model for CBHCs is really having sort of everything in one place, make it easy for people to access the services they need. This is still a work in process. There are still a couple of CBHCs that do not have all of their services co-located, although that remains a goal. And I think the Commonwealth and the project manager of the CBHCs, MBHP, is still sort of working on that as a goal with all of the CBHCs. So that is the desired state. And from Beth, there are 26 CBHC. There are 26 CBHCs, although there are 29 locations. So some CBHCs do have sort of multiple sites. And later on in the presentation, we have a couple of maps and resources sort of showing where that is. So the CBHCs are not operated by DMH. We have been, I think, at the table with Mass Health and MBHP really the whole way in, I think, considering how CBHCs will be integrated into the behavioral health system, sort of how they will link to first episode services. We'll talk about that in a little bit. But they are, the CBHCs are a service of Mass Health, and they're operated by MBHP. Margaret may actually talk about this in a little bit, but I just want to say too that it is not a coincidence that MBHP is both sort of the operator of the behavioral health helpline and oversees the CBHCs. That is a really important sort of point of integration that the roadmap had sort of intended from the start. So that is not a coincidence. Okay, next slide, please. Okay. So as sort of part of this vision of making it easy for people to get the care that they need, CBHCs combine a lot of different services into one. So there are, adult services, there are youth services, crisis services, there are crisis stabilization services, sort of substance use and addiction treatment services. There are a couple more slides that sort of go into more detail about this. But the CBHCs are licensed by DPH. They are sort of fully kind of ADA compliant and accessible. And one of the new, I think, aspects of the CBHCs is that while most CBHC services are licensed by DPH, DMH actually is the licensor for the crisis stabilization beds. But in any case, so next slide, please. Okay. So this goes into sort of a little bit more detail on the kinds of services that the CBHCs offer. I think of them as really breaking into a couple of different buckets. So there's sort of crisis response and crisis care. There's urgent care, which we usually define as sort of care within sort of 20, either same day or within 24 hours. And then there's routine care. So the crisis care, I think what we aspire to is really to have sort of a kind of a community-based crisis assessment and intervention, regardless of insurance. So insurance blind within an hour. That is, I think that is the goal and standard for CBHCs. So the kind of routine services, I think of those as sort of in that third bucket, kind of on the bottom, the care coordination and referrals. So that is more for, individuals who are looking for, sort of support groups, who are looking for outpatient therapy, who are looking for, sort of routine, kind of healthcare related appointments, maybe peer support. I think the urgent care is more, again, sort of for individuals where it's not a crisis in the moment, but it could become a crisis if they're not given, sort of rapid kind of access to treatment. So let's see. So the goal is really to have, sort of an extremely broad range of services easily accessible to people at, sort of at kind of myriad locations and myriad times. So the crisis services in particular are, as always, 24/7, 365 insurance blind. And the other services are not all sort of 24/7, 365, although CBHCs do have, sort of wide-ranging hours, and I think a lot of them do have weekend hours as well. Let's see, was there anything else on this one? No, okay. Next slide. Okay. Let's see. So this, I think this just gives a little bit more information about the crisis services in particular. I think like I was saying, the goal is really to get to people within an hour. And the sort of the CCS services, the kind of the crisis stabilization services, these are brick and mortar services. So there is both sort of outreach based kind of crisis sort of treatment and assessment, and then there is CCS, which are sort of actual physical beds that that people can be brought to. I think the vision for CBHCs that I was saying before of having sort of all services within kind of one location is true. However, the only kind of asterisk on that is for the youth CCS beds, which are sort of administered regionally. So for youth CCS, that may not actually be kind of co-located with the other CBHC services, but all CBHCs have access to youth CCS. Okay. I think the only other thing I wanted to point out on this slide is just around kind of sort of law enforcement and EMT. So this is a sort of growing kind of aspect of CBHCs, and again, had always been part of the kind of mission and vision for CBHCs is to have that kind of community integration. So police could, could drop off people at CBHCs, EMTs could drop off. I think, part of the vision for CBHCs is also to, sort of kind of help facilitate admission to hospitals as needed and necessary. And so some of the sort of medical kind of screening components of CBHCs are sort of designed to sort of help speed that. Although sort of that aspect of the service is still is kind of still being implemented. Thank you for responding to that, Margaret. Okay, next slide. Okay, so CBHCs and sort of early psychosis coordinated specialty care. So, in as much as CBHCs provide sort of an incredible array of services, they do not do everything. And so for a couple of the things which are critical, but they do not do, they are sort of required to at least have a sort of a formal partnership and relationship with another entity that could do these things if they do not do them themselves. So sort of the list, kind of the list of services that fall into this category is here. And first episode, psychosis coordinated specialty care is right there. So we have provided some sort of resources to CBHCs regarding sort of training and sort of other kind of consultative resources. I think Emily and Margaret may actually speak about this more in a little bit. Sort of if CBHCs wanted to provide coordinated specialty care, but it is, it is not sort of completely in their wheelhouse to provide sort of all aspects of this. And so, CBHCs do have to have a way of referring people for coordinated specialty care if they need it, even if they don't provide it themselves. So I think one of the kind of one of the projects that we have been working with MapNet on has been actually looking at sort of proximity of CBHCs to sort of first episode coordinated specialty care programs. Actually, you can keep going, and you can actually go ahead from this one too. I think I already talked about that. So this this again is sort of a kind of inexhaustive list of different CBHC core services, and it's really possible because the model is a milieu space. So there are nurses, there are peer specialists, there are psychiatrists, there are clinicians, there are lots of different staff sort of co-located in the same place, which is why it's really possible to deliver kind of this range of services. Again, sort of make it easy for people to get the care they want, put it all in one place, make it accessible. Okay, next slide. So, yep, thanks. So this is the current map with sort of all of the CBHC locations as of today. So again, there are sort of there are 26 CBHCs, 29 sites, and on the next slide. So all of this is also available online, sort of on mass.gov. So if there, sort of is a kind of a question as to what CBHC you are proximate to, or if, if you're looking for CBHC services for someone sort of in your care, but, they sort of live in a different area and you're not really sure what kind of what CBHC is closest to them. This is the sort of directory of record on the state website, so you can search by zip code. There's a map, and so when you do that search, you will see a list of CBHCs, the communities they cover, contact information, sort of, as well as a whole lot of additional information about CBHCs. Next slide. So we are still collecting sort of information about CBHCs. I think like the helpline, the CBHCs were launched on January 3rd of this year, so they're not even a year old yet. But again, that was very intentional, that CBHCs and the helpline would be launching, would kind of come into being at the same time. That was very much sort of part of the vision of the roadmap. And let's see, and I think the sort of the main, one of the main outcomes that I know that the Commonwealth is looking at very closely is the reduction of Section 12s and, sort of the ED kind of usage and admissions. And from sort of early data is showing that the CBHCs are having kind of their intended impact by sort of reducing pressure on the EDs in those kind of in that area. See, I think that is probably it for the CBHCs.
Thank you, Michael. Shall we take a moment and just see if there's any questions specific to the CBHCs before we go on to the behavioral health helpline? I can't actually see people, but so if you have a question, you would have to raise your hand.
Well, I know, Margaret, you answered this in the chat, but could you say a little bit more? So the really like crisis response kind of immediate piece is open to any insurances, but the more full coordinated treatment in a CBHC for kind of ongoing care, that would be specific to Mass Health and then whichever insurance they also accept.
That's correct. Yeah. Okay. Why don't I go on with the behavioral health helpline, and then we'll talk about empath, and then we'll leave hopefully plenty of time for questions. So the behavioral health helpline, I just want to elaborate. So Michael was saying the purpose of all of these new developments is to enhance and expand, and I would say sort of weave together better the parts of the behavioral health system that operate here in Massachusetts. And the behavioral health helpline was something that people had been calling for, I will say, for 10 or 20 years. The purpose of the helpline was to fill a gap that was not being filled already. And that was to address I think every one of us know, either because we personally have made these calls or we've been on the receiving ends of these calls, when a person is looking for a therapist or a family therapist or a support group, you go to your insurance, you go to a website, you make 2,900 calls and you get 1 or 2 calls back. It's radio silence out there. And so there was a clear recognition that we needed to have a way to reduce the burden on individuals and families that were seeking services to actually connect with providers that are able to offer those services. And so the behavioral health helpline was conceived as the answer to that problem. And so let's talk about what it has actually become. It's meant to be the bridge. So the vision and drive for the behavioral health roadmap was, again, the observation that we here in Massachusetts have, some of the best ratios when it comes to licensed behavioral health providers per our population. I think we're right up there with New York City, San Francisco, and Chicago I think are the hot spots. But people accessing and connecting with those providers are extremely difficult. You have to know someone to connect with someone for the most part. So the purpose of the behavioral health roadmap was, as Michael was describing, to really try to integrate and make, allow people to find the help that they need when they need it at the level of support and resources that they need. So the behavioral health helpline is meant to be that sort of, initially it was called the behavioral health front door, that single point of access where you can call and you can get you can get support accessing whatever your needs are in terms of behavioral health. So you can call if you're in crisis and want to connect with a mobile crisis team. You can call if you're looking for a therapist for your niece who lives in the next town. You can call if you need a support group. You can call for any purpose whatsoever and at any degree of crisis or not crisis. As we've said before, the behavioral health helpline is available to anyone in the Commonwealth of Massachusetts. You can call, you can text, you can chat, and the helpline is available 24/7, 365 days a week. One of the things that you'll hear more about that was really important to all of us was that the helpline not become another number that you call that gives you numbers to call. I think, again, many of us have called our insurance companies and you get a printout with, 100 providers that take your insurance, or, call these 10 and you go off and do the work yourself again. The purpose of the helpline was to take that work away and for the helpline staff to find the people that have availability, that take your insurance, that you can access because they are available through public transportation, or they do telehealth, or they have clinicians that speak your language. And that the behavioral health helpline will facilitate a warm handoff to those resources and services for you. So similarly to the community behavioral health centers, there's a lot of different ways to really elaborate on what the behavioral health helpline is trying to accomplish. I think, so I won't sort of reiterate what I've just said, but I think a key part of it and the development has been making sure that when you call the helpline, that they can also connect you smoothly to the other resources that exist. And so you'll be hearing from Emily Gagan about that smooth transition so that the person calling doesn't have to experience, I'm getting put on hold, I'm getting transferred, I'm getting put off, but I'm getting connected with someone who can help me specifically with what it is that I'm calling for help about. So a huge amount of work has gone into looking at the workflows and how staff are trained to understand what someone is looking for, and if there is another helpline or service that best is going to be able to assist them to provide that seamless transition and support. We spent a lot of time when we were developing the helpline. You heard about, we did a lot of listening. So there were all of the listening sessions that were just about what is the state of behavioral health in Massachusetts in general, what do we need to do better? And that, you heard 700 people weighed in different ways on just the behavioral health roadmap and the need for the community behavioral health centers. And from that came the need for a front door. And then we had additional listening sessions to find out what was important in terms of making a front door accessible. And I don't know that we'll talk as much about this today, so in detail, but I just want to say that there is a whole team, and I kept the slide of 18 people, 16 or 18 people that are based in every single community of the Commonwealth. And their task is to build bridges to communities and neighborhoods that have not typically been able to find behavioral health services accessible, safe, meaningful to them, and to start to build those relationships so that we're not just serving people that already know how to ask for help and are already somewhat comfortable pursuing behavioral health, but that we are entering into communities and partnering with community leaders to make behavioral health accessible to people for whom English may be their second language, or for whom a cultural group for whom mental health is deeply shameful. We're trying to build those relationships and figure out how to make those connections. So we really wanted the behavioral health helpline to be a space that people can call and feel heard and not shamed, not stigmatized, not pushed away, not pathologized, all of the sort of things that we didn't want to have happen. And so a huge amount of work has gone into the training of the staff so that they are listening and they're working collaboratively with people. I think, I think many of us know and have heard that calling crisis is often a threat that is used, certainly to the teenagers that are causing trouble or people that are causing trouble. We're going to call crisis. You're going to have to go to mobile crisis. We did not want the helpline to be a punishment for someone. We wanted it to be a space where people can call, they can get help, and the people that are answering the phone are interested in working collaboratively with you to understand what your needs are and what kinds of resources are available that are going to best help you. So in addition to just the tenor of the experience and the careful connecting to other providers, we also wanted, and we learned a lot from our colleagues at William James College who've been providing a service like this for about 10 years, that it's really important that there's follow-up. Most people call for help and then don't actually take the next step. Many people have one appointment with a behavioral health provider and then they stop going. And so we built into our expectation that the behavioral health helpline is going to follow up with people. How did that mobile crisis evaluation go? Have you landed? Do you have what you need? Is there anything else we can help you with? Hey, you had that appointment with that therapist or that psychiatrist that we helped you set up. Did you get there? How did it go? Do you have what you need? Is there anything else we can help you with? And so with the helpline, we were trying to address not just that it's impossible to find someone who takes your insurance and has availability, but also to address that apprehension that most people have about meeting a new provider, sharing their life story with someone and all that comes with that. And so we were trying to help people navigate through that ambivalence and actually engage with someone. And we wanted to also make sure the message is clear. Just because this person has your insurance and has availability, that doesn't mean they're the right person for you, and that's okay. If it wasn't a good connection, we will help you find another person with whom you might feel more comfortable and be able to make a connection. And then finally, a really important part of accessing and making use of behavioral health services, as we all know, is having childcare, having transportation, having stable housing. And so part of what the behavioral health helpline helps with as well is either if they don't necessarily deliver those services and resources themselves, but they help people figure out how to get support around those social determinants that really impact people's ability to access and make use of behavioral health services. This is a very detailed picture describing everything that I've just said to you. So I will pass on by, but we will share this with you. Some people are more visual, some people are more verbal. I think actually one thing I do want to really emphasize is the efforts that we are going to, and let me just say we are not there, but we are aware of how hard we have to work to have the phone lines staffed by people who speak multiple languages, who are ASL fluent, so that we really can be truly accessible to people across the Commonwealth. And actually, I hadn't mentioned this before. So the helpline is staffed by bachelor's level, master's level clinicians and peer specialists. And typically you will have the bachelor level or master's level clinician answering the phone, and then the follow-up and ongoing support would come from the peer specialists. And I guess I should say a little bit more. Part of what the helpline does is working with you to sort of collect the information that's needed to make a determination about what a good plan would be, or what resources and support will be most helpful to you. And so there is a clinical assessment that the call takers conduct to help sort of sort out what would be most helpful. So this here just talks a little bit about what we mean by a warm handoff. And I'll just say briefly what it means is usually you're on the call with someone from the helpline and they initiate a three-way call with the provider that you may be connecting with. So it's, again, not just here's another phone number to call. The other thing that we have tried to really work on is to reduce the demand for people to repeat their stories over and over again. And so with the caller's permission, the behavioral health helpline staff will share information with the receiving provider to try to reduce the kind of redundancy of requests. And then the behavioral health helpline call taker will leave the call sort of when everybody is comfortable, and the caller and the new provider can sort of make their own plan together. And then the helpline will follow up with the caller subsequently. This is just an example. So information is, in addition to sort of that three-way phone call, the helpline can then send a copy of the sort of triage and risk screening and clinical assessment that they've documented from the call with the caller's permission to the new provider. I'm going to just run through a couple numbers super quick. I just thought it might be helpful for people to hear what's been happening. So the helpline launched January 3rd, and this data is from our April report, but I did look at sort of numbers from May and June, and pretty consistently we're getting we're getting about 900 calls a week, around 150 a day. Someone can do the math. I think that works out, 135 a day. And they're coming, you won't be surprised. Middlesex County, I think, generates the most, at 20% of the calls. Worcester is 15%. It's probably relatively proportionate to population. And these are the kinds of things that I think all of us are interested in, sort of when someone calls, what typically happens. And I think it's helpful and important for people to know these are absolute numbers, but I think it's 1%, maybe 1.5% of calls actually are someone who's calling in crisis and needs mobile crisis or even 911 to take someone to the hospital. So we'll just say 98 just to be conservative. 98% of the calls are people that are looking for assistance, either, I think it's, 25% are referrals to mental health. And you'll see often what people are calling is just to get information. And then they want to think about what their options are and decide what their next steps are. So I'll come back to this if people have questions down the road. We can look at these numbers. I just thought it'd be interesting to see that 83% of the callers in April were either the individual themselves or a family member calling on behalf of an individual. Only 5% were professionals. Professionals can call, teachers, you know, if you're working with someone and their son needs help, you could call on behalf of your patient's son. If you're a primary care doctor's office, so you can call to find someone for your patient. But primarily it's individuals calling themselves. And then it's just interesting to see that they're getting about 13% of callers are repeat callers. And sometimes those are people for whom they've had crisis and then they have another need or service. And so they're looking for something else. And sometimes they're people that have found that the call takers are good listeners and warm and empathic, and that they feel much better after calling and talking to the staff members at the helpline. Generally, we're inviting people who just need someone to talk to call 988 or call some of the other warm lines, but they can always call the helpline and figure out together whether the helpline is what's most helpful to them or whether it would make sense for them to work with other warm lines for that purpose. This is a lot of color. And one thing I want to say about this, so this is looking at some of the clinical data that they have collected in talking with callers. And I just want to acknowledge that the numbers of people that are calling with psychosis or early psychosis has not risen to the level that there's a pretty graph about it. But in looking at this, I was thinking that's a question we're going to have for them to share that, to share what those numbers are for us. So you can see here that we're looking at, you know, what percentage of people have a current. There's a lot that's sort of unknown because that question may not come up depending on what the nature of the inquiry is. But, you know, there's, what did they say? I think it's 24% of people that have had suicidal ideation. So we're looking at suicidal ideation, a history of substance use, a history of domestic violence, thoughts about hurting someone else. These are the kinds of risk questions and assessment that's happening. And then part of the role of MapNet has been, as Michael was talking about, is we are working with the Behavioral Health Helpline to train them and the staff at the CBHCs to recognize early signs of psychosis, to understand how to talk to individuals, young adults, how to support a family when they're concerned that someone might have psychosis or they have a family member who does have a psychotic illness. And what are some of the clinical skills that are needed? Because not everybody is going to need coordinated specialty care. While we're standing up more coordinated specialty care programs, we need our behavioral health providers across the state to have the ability to talk with people and provide some clinical support as well. And so doing a lot of training, as MapNet has for years, with the Behavioral Health Helpline staff, the CBHC staff, and other community providers. And Emily will talk a little bit more about that. And then, as Michael alluded as well, clearly CBHCs are expected to have a relationship with a coordinated specialty care team if they themselves are not offering coordinated specialty care. And we have less than 20 coordinated specialty care teams in Massachusetts, and we need probably 50 or more in order to meet the demand and the requirements. And so that's something that MapNet is working with all of us to raise the numbers of coordinated specialty care programs in Massachusetts. I am not going to elaborate on this other than to say we will send the slides out, and there are There's a clearinghouse where if you want swag that shares information about the behavioral health helpline, and you can hand it out to people so they can readily get the number, know what to call. These are the, I guess it's not 16, these are the many people, 12, 11 people across the state who are working to spread the word about the behavioral health helpline and the CBHCs, and to help break down those barriers for people. And oops. This will be in the slides when we go out, but it's sort of lots of different places you can go to get information about the CBHCs, or to access the promotional materials, or just frequently asked questions. And that is it. I will turn it over to Emily now.
Thanks.
And I'll look at the questions. I should look at the questions.
Yeah, any questions we want to address before we switch over to talking about empath?
I think just to reiterate what the question from Seth and Michael's response, that the CBHCs are, as you saw on that slide above, they're required to have a formal partnership with a coordinated specialty care program, or to offer the service themselves. Most of them are not offering the service themselves at this time. They may, in the next couple of years, decide that's something they want to do. Most of them have agreements with coordinated specialty care programs. And that's something maybe we can talk about after, Emily.
Okay, sounds good. So let me share my slides. Okay, so I'm going to explain a little bit more about empath in particular, which is the Massachusetts Psychosis Access and Triage Hub. And as I think most, if not all, the folks on this call are aware, right, early intervention for psychosis is what research tells us is best, and what sets people on the best trajectory for long-term outcomes, and can be really life-changing. But clinicians often don't feel, at least, like they have the skills or the knowledge to respond when folks that they're seeing may be experiencing psychosis, or the knowledge to identify whether what someone's experience might be psychosis. I think Massachusetts is pretty unique in that there are a lot of these kinds of clinics in comparison to other states. But as we've already talked about, it can be really difficult to navigate the mental health system broadly, let alone trying to figure out where is the best fit for one of these specialized clinics. A lot of them have different, criteria in terms of who they're able to serve, and things like that. And families and clients then, and providers, when people are experiencing these kinds of symptoms, can feel very confused and overwhelmed, and in often sending out referrals to a lot of programs at times, which then also creates more work for the already overtaxed programs in terms of, duplicative work of getting information from people and things like that. So the hope was to create more of a centralized hub that could provide this kind of consultation, triage, general information, and things like that to ideally streamline the process. So we did a lot of talking with a lot of people in terms of trying to figure out how we can do this, and what are the gaps in terms of what people are needing, and what people, both providers, feel like they don't have, and what clients and families and people in the community feel like they need. Of course, we, have in collaboration with DMH quite a bit. DMH provides the bulk of the funding for this program. But as Margaret mentioned, we've also worked pretty closely with the helpline and with MapNet to provide training and consultation for them as well, for them to be better able to identify psychosis and to know when would be appropriate to send, referrals to us, things like that. But we've talked to a lot of other folks in the community. So if people are familiar with MCPAP, the psychiatry, child psychiatry consultation service, of course, the LEAP Center at McLean Interface, which Margaret mentioned, is the program at William James that has done this kind of referral work for many years. The PPOC, the Rape Crisis Center, some inpatient units, a network of care, the Link Kid Child Trauma Therapy Referral Network, which also is pretty similar to what empath is setting out to do, but does it in the context of child trauma therapy referrals. Bright. And then, of course, we also talked quite a bit and continue to talk to the early psychosis and CHR programs directly to hear from them in terms of, the kind of work that they are doing when they receive referrals and knowing when to, how to refer people out if they're not able to take them on. And so for us to have a clearer back and forth with them so that we're also not creating more work, but providing, additional support to them, and them also being a destination for us to be able to refer people to. So we came up with this model, which is, the overall goal, of course, is to shorten DUP and to connect people with treatment. I think a related goal is to increase access to treatment and more equitable access to treatment. I think, as is the case with a lot of resources, it's people that, have knowledge, have resources already in the community that are able to access them. And so we're hoping to also reach communities that may, not have as much knowledge or access to that, so that we can help with that as well. So it's a number of different things that we're seeing as being things that we can provide. So statewide outreach, both to let people know about our services and that we exist, but also education in collaboration with MapNet. We've already been doing a number of trainings to let folks know more about what they can look for, like what is psychosis, what are the signs, things like that. We've been thinking, or I've been thinking a lot about this in terms of how we can help providers in the community deliver psychosis-informed care. So that means that people perhaps are not everyone needs to be in a coordinated specialty care program, right? Like not everyone needs the higher level of services, but in the way that we think about trauma-informed care, not everyone is an expert in trauma, but people understand, or in my opinion, it's important for people to understand the impact that trauma can have on someone's presentation, their experiences, things like that. And so we're kind of hoping in a similar way, Empath can be providing this consultation and this support to providers so that the clients they are working with, they are providing them with this kind of slightly more informed or slightly more specialized version of care so that they feel better equipped and clients are receiving, even more well-informed services. And then, of course, screening and referral, which is a big piece of our work. So we're hearing from folks, and this means hearing from clients themselves, from families or friends of folks, and then also from providers. And I'll talk in a little bit about the preliminary numbers we have on that so far, but to hear more about what's going on and how we can best help, and then talking about next steps. And next steps can be a number of different things. It can be, of course, facilitation of a referral to a coordinated specialty care program, but it can also be supporting the provider, as I was just talking about, with continuing to work with that person. It can be, thinking about some other programs in the community that could augment the work that they're doing or the providers that they're seeing. But just trying to get a better sense of what's going on. And then if we are working with folks on a longer term basis, as we all know, there are wait lists at a number of these programs. There can just be delays in the, getting folks connected. And often wait lists are where people can fall off, right? And so in the same way that Margaret was talking about how important it is, even within a short-term period, to follow up with people to see, how did that go? Did you get in? Did you go to the appointment? If people are looking at a 3, 4, 5 month wait to get into a coordinated specialty care program, our goal is to be checking in with folks regularly as well. So Empath is not providing clinical services. We're not providing individual therapy. We're not prescribing medications. But what we do want to do is make sure people have a connection in that interim period. They may have, we are planning to make sure they have providers in the community if they need them for those kinds of services. But if there are ways that we can help people prepare for treatment, if they can, we can answer questions about what this kind of treatment might look like. And we're hoping to do that with through a couple of different avenues. So we're hoping, which I'll talk about in a second, hoping to hire a case manager, a social worker, a care coordinator type of position that can help people also with more practical things. Like if we're thinking a DMH application might be a helpful piece of the puzzle, or other insurance issues or things like that, if we can help people with those things. And then we're also planning to hire a peer support specialist and a family partner, and hoping that those two positions, they'll be doing a lot of that connection and support in that interim period, particularly because if we're talking about getting people into coordinated specialty care or any sort of psychosis specific treatment, hearing from people, particularly for the clients, but also certainly for families who have already done something like that, I think, as we all can imagine and we already know, goes a long way to perhaps increasing engagement when people do get to the point of starting treatment. And then, as I said before, consultation, and that consultation can be kind of a one-time thing where we're talking about diagnosis and symptoms and is this psychosis? Is it not? You know, what should be some next steps? But also longer term. So if there's someone that, you know, a person is seeing in the community, we can check in with them multiple times and say, okay, well, we met last time and said you were going to try these couple of interventions. It's been 3 or 4 sessions. How did that go? What are some next steps that, you know, could be helpful for you to think about moving forward? And then also follow-up. So as we were just saying, we want to check in with people if they're on a wait list and waiting, but also if we've kind of, this is a moving target, but, you know, ended what we are doing with folks right in that moment. We've kind of connected them to a service, or they did get an intake or things like that. We're trying to follow up at least a month later to say, how did that go? You know, are there other things that are going on that you need help with? And can we help with those? You know, we're small, and so we're not closing cases and kind of needing to readmit people or anything like that. So we're kind of seeing how it goes. But so far, it's been really important in a number of cases to do that follow-up and hear from people to hear how things are going. And that also allows us to do some more collection of information about outcomes, and which can, of course, inform how we continue to provide services moving forward. So this is our team. Rebecca is our program coordinator. She's the person who's answering the phones and answering initial emails or initial outreaches from our website and getting information from folks. James, or Jimmy, is our data coordinator. He's been also with Cedar before this and has a lot of experience in this area as well, and has been integral in setting up our data systems and the website. And then Henry White, who I imagine maybe many of you know, it was the founder of Empath and kind of the creator of the program, and still continues to work with us as we're getting off the ground. Also, Dr. Emily Klein has been a consultant and a great member of our team as we've been setting this up. And then, as I mentioned before, we're hoping to hire these folks in the very near future. The care coordinator, the clinician, the peer specialist, and the family partner. We are a program of the Brookline Center, and as such, we've also worked really closely with the Cedar Clinic. We started piloting our services in November, and that initial pilot was solely through referrals to the Cedar Clinic. And so as they came in, we took on some of them that perhaps weren't a great fit for Cedar, or that, you know, they needed help with. And so they've also been a great collaborator as well. Excuse me. So I think I've covered most of this already, but just to kind of review, for providers, and when I say providers, I mean outpatient mental health folks, but also PCPs, pediatricians, school-based folks, and college-based folks. ED staff, inpatient staff, whoever it is that we might be able to help, who feel like they may not have the expertise in psychosis or the information. We can provide that diagnostic consultation and education regarding, what is going on with folks in the moment. We can do more ongoing consultation. And then also, certainly, if it does seem like it's appropriate to refer clients to a coordinated specialty care clinic, that we can do that as well. For clients and families, it's the triage, trying to help people navigate this, extensive but at times confusing system of specialized care, and figure out what might be the best fit for them based on all of the criteria that are going on for them, how long the person's been experiencing symptoms, their age, of course, insurance, which is always a mess, location, among many other things. And then that's that navigation to those programs, if again it seems like a good fit. And then the care coordination and support throughout that process, and the follow-up in the interim, in part looking like the peer and family support as we are hiring those folks. So just a little bit about who we're hearing from so far. So like I said, we started piloting really in November. We've heard from 60 folks, although, like I said, some of those were the CEDAR referrals that we were starting out with. So they weren't people who were contacting Empath directly. But as we've continued to do outreach, we're getting many more calls to us specifically. We're hearing most from providers, which is different than the helpline, of course, where it's sounded like folks were providers were a smaller piece of the puzzle. I think that has a lot to do with our outreach. We've outreached mainly to providers and provider organizations rather than doing any sort of kind of community, or at least not as much community outreach to clients and families directly, but we are going to continue to do that as we expand. The ages of folks, it's interesting, providers seem to be calling us about the youngest folks, as opposed to clients themselves or family members who are calling about perhaps slightly older people. And as you can see, our calls have increased over time. We've, our numbers are small, but we're increasing, and Rebecca continues to get more emails and calls each day. This is a perhaps somewhat zoomed out, but a general look at where our calls have come from. Again, this includes the CEDAR referrals at the outset as well. They're mainly on the eastern side of the state, which we might expect because a lot of the outreach we've done is to programs on this side of the state. We've been thinking about how we can reach out to folks on the western side of the state. I think we've been, trying to be thoughtful about it because we know that the early psychosis resources in the western side of the state are more sparse. And so thinking about how we can kind of frame what we can offer as very consultation heavy. And so for the folks that are seeing people out there, we are, more than happy to provide that consultation so that people can continue to see the folks that they're seeing, but have some additional information to do so. How have people heard about us? I think the majority have been through other mental health providers, which again makes sense. That's kind of the majority of the outreach that we've been doing. We have heard some from the helpline, who, as Margaret was saying, kind of trying to do that warm handoff to us. Also from hospitals, people have found us on Google already, which is exciting. And then some family and friends and primary care folks as well. In terms of the kinds of things that we're helping folks with, these are broken down by the person who contacted us first. So I am the person seeking out the client themselves versus a friend or family member versus a provider. We've certainly referred a number of folks to CHR programs and to early psychosis programs, also to general outpatient services or DMH. Sometimes we're just providing some resources, information. So it's family members that are saying, my loved one is not really interested in treatment yet, but I'm not sure what to do. And so we're sending them, information about NAMI or about Milo, Dr. Klein's intervention, things like that. And then again, offering them that continued follow-up with us if we can be of more help or if things change for them moving forward. A number of times we're just supporting the provider to continue to see that person. So like I said, helping people to provide that psychosis-informed care where it may not be necessary to refer someone to a specialized program, but it may help the provider to have this additional information and education. At 1 month, there's of course a lot fewer that we have in terms of contacts thus far, but we have seen a number of folks have been connected to their first appointment at a program or already have begun services. Also, people have connected to non-psychosis related services, but some sort of mental health service. And then there have been some folks that we haven't been able to get back in touch with. And then in terms of what folks might need additionally at 1 month from the last time that we talked to them, as you can see, the folks that are reporting they still would like additional assistance are friends and family, right? So they're still hoping to find a support group or decided they might need a support group or additional resources and things like that, whereas providers have generally felt comfortable. I mean, these are small numbers, but comfortable with where they're at and kind of knowing that we're available always if people want to reach out to us again. So yeah, so that's the summary. We are available via these methods of contact, phone or email. Our website has online contact forms. I was going to say something else. Something that we perhaps don't emphasize as much as we should. We are free also. And so that's been something that a lot of folks have asked us about and kind of said with trepidation. And how much is this going to cost me, or how will my insurance cover this? And so I think that's been a relief for people to hear that we are available. We're not an emergency service. That's absolutely the helplines area. So we're kind of a 9 to 5, Monday to Friday service. However, we are getting back to folks within 24, if not 48 business hours, and are able to be quite responsive in that sense. So yeah, happy to answer questions about this, or we can kind of open it up to questions for everyone. I can stop sharing my screen.
Well, and we had a great question from Corey in the chat, which you may have answered in some part in the graph that you had showed, but what percentage of people roughly that are calling you do you think are actually, in a first episode of psychosis or appropriate for early psychosis treatment?
I think I don't know if I want to venture to try to give you an actual number, but I do think, we are trying to be really thoughtful about where we are directing people to go. So then if we are suggesting someone go to a program, more often than not, we've already kind of checked off most of the criteria. And also, Corey, yeah, sure. But to, further clarify, that, or we've even reached out to the program. So that's another reason why it's been important to us to develop those relationships with the programs, is that we've reached out to them to say, we heard from this person, here are the reasons why we think they might be a good fit, any hesitations, things like that. So hopefully trying to kind of cut down on the number of times people are reaching out to a program and then finding out they're not a good fit and having to start over. I'm sure that will continue to happen at some point, but part of our goal. And also, number of programs in the state. I think I always forget the total number. I want to say it's 14 that are currently active and accepting folks, and then 3 clinical high risk for psychosis programs.
Thank you, Emily.
So see, there was a question about the number 1 item and about empath outreach to the state. So like I said, we've been working with MapNet to kind of collaborate on outreach to various groups as MapNet is hearing from them, if they would like presentations or education. We've also tried to be pretty directed in the groups that we are reaching out to, mainly because I wasn't sure what kind of response we would get, and I didn't want to be overrun. And so we've been kind of like, as we've reached out to various groups like MCPAP, like the helpline, like, inpatient units, we've told them we've opened our door, our doors are open to you, please contact us, things like that. And so we're kind of continuing to do that, like I said, now with a focus towards the western side of the state, so we can continue to identify some groups out there that we can do the same thing and say, here's what we can offer you, please let us know if we can help in terms of education, but also if you have folks you'd like to refer to us or to talk to us about.
Hi, this is John Knudsen. Do you mind if I just jump in and ask a question, Emily? So looking at that map, I just want to ask about what you see empath and how we can work with empath as so I work for ServiceNet, and I work with the Prep West team, right, the early psychosis program based out of Holyoke. If you look at that map that you showed me, right, like the catchment area for early psychosis is sort of approximately half of the state, and I'd love to have some of those purple dots out in the West. So I'd love to work with you, and I guess my question is, what are your thoughts about how quickly we could sort of expand and provide a broader network and area of coverage for the entire state?
Yeah. So I've talked to a couple of other folks at Prep West thus far, Michelle and the director of Prep West, whose name has escaped me, but
Melissa?
Yeah. But Betty, yeah. No, I absolutely. In fact, we just had our team meeting on Wednesday, and we're talking about the specific groups we wanted to reach out to do that. And so we're more than ready to do that. I think, as I was saying, I think we want to make sure to be framing it to folks as like, I'm not sure how much connection to specialized services that we will be able to do in the western part of the state, just because of the limitations of what's out there. If there's, if it's appropriate for Prep West and Prep West has availability, for example, absolutely. But more so, we are more than happy to do a lot of consultation for people that are seeing people in the community that may be having these experiences, and do presentations for folks to provide additional education. So we can absolutely connect offline, but yeah, that's something we're really wanting to move forward on quickly.
That's great. Thank you.
Mm-hmm.
And a great question in the chat for you, Margaret and Michael. I definitely have seen some billboards for the helpline and gotten some targeted Instagram ads. Can you talk more of how you guys have been doing outreach for those?
Yeah, I can speak to about that a little bit. Margaret may actually have more updated information, but I know that there is a sort of dedicated sort of promotional advertising campaign for the helpline. I have gone to fill up my car with gas a couple of times and have seen helpline ads on those screens on the gas pumps. I've heard radio spots. I think like Margaret said, there's also sort of helpline swag available sort of on the helpline website. The CBHCs are a little bit more decentralized, so I'm not aware of sort of a centralized advertising campaign for the CBHCs, but the helpline is a statewide resource. The CBHCs are more local. So, I think each CBHC, has been sort of outreaching and developing relationships kind of in its community with, key stakeholders, with, police departments and schools and, DMH offices and DMH providers and et cetera. But I guess on the sort of helpline front, Margaret, is there anything you would want to add?
I would say that sort of even before we were able to get the CBHCs and the behavioral health helpline established, one of the things we've been working on is something that's called the Network of Care, which is a central website where you can search for different kinds of behavioral health services. And at some point that is going to fall under the auspices of the helpline, because similar to sort of one number you can call, we also wanted one website you can go to and find support groups in your community, or, you know, where there's detox, or, you know, where there's coordinated specialty care programs. And so I posted Network of Care there. They are spotlighting the helpline. We're actually, part of the purpose of this talk was both to give you information, but also then to send you out as ambassadors. So please go to that website where you can get your magnets and your pens and sticky pads that have the BHHL number on it, and get as much as you've got, and then put it in your waiting room, hang it on your bulletin boards, share it widely. We really need to get the word out.
I see a question in the chat from Beth. How do we apply to be able to be part of this a CBHC? I'm an outreach worker currently and would like more experience. Actually, could you, I guess, say a little bit more about that, Beth? I just want to be sure I understand the question.
I'm just gonna unmute myself and just ask this way. I'm currently going to school, or I went to school for community healthcare worker, and I'm doing my apprenticeship right now for an outreach worker, but with just like more experience, because I'm also going to continue my education for, I would like to eventually be like a social worker, and I also would like to take classes on like substance abuse and mental disorders and all that, just because it is very common, both of the different aspects, and they just how they kind of coexist with each other, if that makes sense. I kind of get my words out, sorry. So I would just, I guess, want more experience on learning. I guess I don't know if I can get that. It sounds good in the head, but I'm just trying to get it out.
Beth, if you're looking for more training or work experience, I just put in the chat the link to the behavioral health centers. Right now, each of them is a separate agency. So like Elliott Mental Health or ServiceNet Community Behavioral Health Center, each of them are different providers. And so you do have to go to each agency and see what the jobs are that are available. But that's a really good suggestion. I think that you're also, that I'm going to take from what you're also offering, which is that it would be so nice if there was a central like job board for behavioral health, so people could see just across agencies where there are positions and where there are training opportunities. But if you're looking for something super specific, I want to invite you to, I think our contact information should be available. I'd also be happy to talk with you a little bit more about what you're looking for and what kinds of internships might be available.
I would like that. Thank you.
Sure. Yeah.
One thing, if we have time, Michael, I wanted to go back to a specific piece you had mentioned about collaborating with police departments and emergency responders. That wasn't something that I'd heard of the CBHCs doing before you mentioned it. So can you talk a little bit more about what that's looked like and how that's kind of played out?
I mean, I think both of those relationships are sort of still under development, but again, that was part of the original vision for CBHCs. I mean, I think in terms of, I guess for both police departments and emergency responders, again, the idea is that individuals could be sort of evaluated and treated at the CBHC without having to go to the emergency department. So basically that means that the CBHC would sort of functionally be open 24/7 to receive sort of police drop-offs or sort of EMT drop-offs, and where they could complete a sort of crisis assessment, where they could refer somebody to the CCU if that's what was called for, or they could make an appointment for the person for the next day if they need sort of urgent kind of urgent care. They could refer to somebody to sort of higher levels of care if needed, but basically that the CBHC would be a sort of an in-between step between sort of those frontline staff and the ED.
Yeah, that's great. Well, and it strikes me as especially important for our psychosis community in Massachusetts. So yeah, it's great to hear about that.
Yeah, I think sort of on that kind of in that vein, what one thing I had forgotten to mention was, I think for that reason, because the CBHCs sort of are providing that kind of crisis level of care, and they are kind of stitched together to the behavioral health helpline. We're sort of continuing to sort of message and encourage programs to just communicate to their staff and to the people they serve that rather than calling 911, rather than going to the ED, please call the helpline, sort of to sort of for that assessment, for that that kind of crisis referral. And then, if somebody really needs to go to the ED, the helpline can still facilitate that. It's not mutually exclusive, but, I think often people don't need that level of care, and they just go there because that's what they know and that's what's accessible. And so, sort of with CBHCs and the helpline, we're doing everything we can to make sure that people understand that the helpline and the CBHCs are also accessible, and that kind of in that way that they are an in-between step for sort of frontline staff. They can also be an in-between step for individuals and families. So. Any other questions?
I'll just say thank you to everyone. And please, if you think of more questions, don't hesitate to reach out, because we'd love to. If you also have suggestions and ideas, sort of, because we're trying so hard just to transform the behavioral health system here in Massachusetts, and with that to raise the level of knowledge and competence that the entire behavioral health system has to recognize people experiencing psychosis, to talk with those individuals, to talk with family members, to support family and others. And so in addition to the specialized services, this educational campaign and effort is huge. So if you have ideas about, if you want to invite Emily or Nat and Kelsey or any of us to sort of come talk to people that please reach out. We want to go west. So we're coming, John. We're going to actually want you guys doing some of the talking. we want to reach the communities of Massachusetts that don't know that we exist and don't know that we have something to help. And we also want to hear if we're doing something that's not helpful, or there's something we could do better to be more helpful, we want to hear that. So we appreciate everyone being here today, and please reach out.
Well, and thank you to Margaret, Michael, and Emily, both for talking today, and also just for all of your work on this. It's really exciting to hear. All right, with that, I guess we can wrap up, and Lola will be sending out a follow-up to everyone. So thanks everyone for joining us today.
Thank you.